Good morning, everyone, and welcome to this I3h seminar. Today, we are really very pleased to welcome MARISA MIRALDO. MARISA is Associate Professor in Health Economics at Imperial College Business School in London. And in the past, she has held academic appointment at the Center for Health Economics and the Departments of Economics and Related Studies at the University of York. Actually, MARISA has a PhD in economics from York University. And she has a track record in leading multidisciplinary research, so it's very much in line with our approach at I3h. Obviously, she's working mainly in health economics and policy, and she's collaborating with policy makers. And she's a fellow at the Imperial College Data Science Institute and currently leads the health research stream at the Data Analytics Center, as well as the Health Foundation funded research program. And she's working on the determinants of the adoption of innovation for chronic conditions such as cancer, cardiovascular disease. So she's also working outside UK. For example, she's a member of the Health Parliament in Portugal. And she's an active advocate for inclusion and diversities and chairs the Diversity Committee at the Imperial Business School. So, MARISA will not be longer. It's a real pleasure to have you, and it happens that we have some indirect connections through Sofia Amaral Garcia. Probably you know that Sofia just delivered a wonderful baby, so I'm not sure she will be with us. And the other connection is my daughter-in-law. She's currently so busy in teaching at Imperial that I'm afraid that she will also not attend, but this is recorded, so it will be a pleasure to send the recording to both of them. So I will not be longer. I think that your topic of today is very close to some of our current interest at I3h, together with Vincent Donquier, head of surgery at our Cancer Institute, at the Bordet Institute. So I think that what you will tell us about, innovation, diffusion, and physician network in relation to cancer is of great interest to us. So without further introduction, I give you the floor for your presentation.
Thank you. Thank you very much for the invitation. It's really a pleasure to share my research with the center, which work I really follow quite closely because it's very interdisciplinary and policy relevant. So many congratulations to you all. So this piece of research, it's on the determinants of the diffusion of innovation. We look at the case for keyhole surgery for colorectal cancer in England. And this is joint work with Eliana Barranho, and I need to acknowledge our fantastic funders, ERC, but most especially the Health Foundation that have funded this large research program on the innovation diffusion. So just the aim of this presentation is really to understand the role that physician characteristics, and I call them consultants because that's how we call them seniors in England. So you will hear lots about consultants, but these are senior physicians. So you want to understand the role of physician characteristics, in particular their networks, and the effect of the peers in the adoption of medical innovation. Now, networks have been shown to be important determinants of behavior, including the adoption and diffusion of innovation in many key areas of the economy. And this is either through information diffusion or peer effects. And healthcare sector is characterized by high levels of innovation, but also we have that physicians collaborate with each other. They train in teams and they get highly specialized. So you would expect networks to play a key role in their decision-making with regards to innovation. Yet when you look at the literature, you find very little robust evidence that identifies the causal impacts of networks and peer effects on adoption and diffusion of innovation. If you look at the health economics literature more in particular, it's widely known that there are large residual differences in practice variation across physicians that are not explained by patient characteristics or hospital characteristics, further suggesting that there is something specific to the physicians that might be behind the variation, the practice variation that we observe. So we studied the extent to which the adoption of an important innovation in surgical practice is associated with characteristics of senior physicians, their work networks, and the behavior of their peers. In terms of setting, we do this in the context of laparoscopic surgery for colon cancer in the English NHS. So the innovation we look at is laparoscopic surgery for colon cancer. Why we focus on these? Well, this is not news to this audience. I always need to remind economists that this is an important policy area. So colorectal cancer is the third most common cancer worldwide, and in England accounts for 10% of all cancer-related mortality, and it's also the most expensive cancer to treat in NHS. So it's highly relevant from a policy and public health perspective. Laparoscopic resection is important innovation that has been found to be associated with improved survival and better shorter-term outcomes, but also to be cost-effective with regards to the alternative that is open surgery. Importantly, we have chosen laparoscopic surgery because we observe the take-up of this procedure in our data that starts in 2000, and 2000 was the year that this was introduced in England. It's almost exclusively undertaken by senior physicians, so our consultants that are the people we observe in the data. There's no capital investment required, so to some extent we can abstract from hospital level considerations with regards to buying equipment and establishing capital infrastructure. And we focus in England because England, to many other healthcare systems, is a single payer setting. As the NHS, everything is centralized. So surgeons and hospitals operate under the same rules and financial incentives. Doctors are salaried, so get a salary, so they don't get paid depending on the treatment they provide. So to some extent, we can better identify the role of networks and the peers on the adoption of these innovations. And very importantly, there is no patient choice in this setting. So even though there is patient choice in England for some procedures, for cancer surgery, because England has very strict waiting time guidelines, patients can't choose where to receive treatment. And again, this is going to be very important for us in our identification strategy with regards to identifying the causal impact of networks and peer effects. So just to give you a bit of background in terms of timeline, so laparoscopy or keyhole surgery was introduced before in other areas other than colorectal cancer. So it was first introduced for appendectomy and cholecystectomy in Germany in 1985. From then, there's been a range of studies that showing its effectiveness in the context of cancer, in particular in colorectal cancer. And as a consequence of those studies in 2000, it was introduced in the UK. Since then, there have been a range of RCTs in Spain, US, and the UK. In the UK in 2005, that led to the National Institute for Clinical Excellence, that is the authority or the institute that does cost effectiveness analysis and issues guidance in England, to publish the cost effectiveness analysis of laparoscopic surgery in comparison to the alternative open surgery, and establishing it as the cost-effective surgery for a subset of the patients that for which laparoscopic surgery will be indicated. So even though this is the timeline, when you look at the data, you see here highlighted in the red bars that in 2014, so the end of our data set, there were still 30% of the surgeons that only did open. So they didn't offer laparoscopic surgery at all. So there is a bit of heterogeneity on the adoption adoption behavior of this procedure. And this is what we want to explore in our data. So we started, so this is part of a large research program. So there's first we did a qualitative piece of research in which we interviewed these senior surgeons. that provide this type of procedure. We were interested to understand what were the determinants of the adoption and the diffusion of these procedures. We did several interviews with the senior physicians, and then using this methodology from the marketing literature that maps the journey to a decision, that basically asks people to think about going back in time, the journey that they followed up to the moment. So this methodology enables you to draw journeys to adoption for each individual and split that journey in three main moments: pre-phase, adoption, and post-adoption. And then basically it maps the factors that trigger the behavior of the individuals towards the adoption or away from the adoption of this innovation. I don't want to waste too much time into these details, but so here you have the journey to adoption for 3 adopters. And what is very clear from these interviews and these journeys is that peers were cited as having an influence, and for the adopters as influencing them positively towards the adoption of innovation. We also did that for the laggards and the non-adopters. And again, we find that peers play an important role. Here it's a bit more mixed. So peers might either trigger the decision towards adopting this procedure, but also often to shy away from adopting the procedure. So here you have more readable, larger font size comments that came up from those interviews. And it's very clear from them that peers do play a role. So for example, we asked these consultants, how do you learn about innovations? And almost the vast majority of them told us that they learn it through their peers. So we learn it through attending meetings, through scientific meetings, and basically we talk to each other. That's how we come to know about the new innovation. Another one told us it's about, we hear it about it by word of mouth, by discussing with colleagues. And interestingly, he says colleagues within the same institutions, but also in other hospitals. So it's alluding that it's the professional networks that are important mechanisms of spreading the information about these innovations. And then we start understanding what are the mechanisms by which the peers, the colleagues can have professional contacts, can have an impact. And there was one particular consultant that told us, well, it's certainly peer pressure. I didn't really want to look like a dinosaur, and so I ended up adopting that innovation. So alluding that peer effects are important. And then a couple of other consultants told us that it's important to peers are important because it's important to learn about their experiences, whether they have succeeded or not with innovation. But even when they have failed to innovation, the way they got around it and the fact that they persisted in keeping that innovation was important was an important signal that convinced this consultant to adopt. And then this final comment here, this final quote here, that it says, well, it's to some extent that alludes to the fact that, okay, it's about talking to people, but importantly to those that have adopted the innovation. And he also says that it's not just talking to one people, but to a range of people, alluding that the network size and the number of connections and that each consultant might have an impact on their innovation. So what we want to do is to test this. So the role of professional networks, both characterized by the connections within hospitals, but also how they are connected with other peers in other hospitals, and the size of the networks, the natural characteristics that we measure with mostly with size, number of connections, and then the mechanisms by which peer effect, so the peer effects and information sharing across each consultant network. So this is what we wanted to test, and in particular to identify the causal impact of these. So in order to do so, we we build a quite rich data set that starts with patient level records, hospital episode statistics in England, where we observe all patients treated in the NHS in England from 2000 to 2014. So there you have everything about what procedures the patient got, the characteristics of the patients, as well as an identifier for the physician that we can follow over time. And then we link that data with the workforce statistics and the General Medical Council register that gives us a bit more information about those physicians. So it tells us where they have trained, their gender, but also where they have worked in the past. So with these data, we can build the networks of the physicians, and networks we define as connections to people you have worked with in the same hospital. And quite importantly, we can map those networks even prior to 2000. So we do it from 1992 to 2014. So for our consultants, and a large share of it, we can observe most of the period for which they have been practicing as senior consultants. Now, even though we have all patients, we restrain the data set to those patients, those colorectal cancer patients, for which there is effectively a choice between open and laparoscopic surgery, because laparoscopic surgery, it's not suitable for patients with very advanced cancers with multiple metastases. And for that, and for those patients, it's open surgery. It's the gold standard. So we using the procedure called classification, we have restrained to those patients for which effectively laparoscopic surgery would be a choice. So this gives us a sample of 3,522 consultants and more than 276,000 patients. Because this is a very low volume procedure, we have further restricted the consultant sample based on volumes. And so we restrict to those that do more on average than 6 surgeries a year. We had some consultants that did, for example, 1 or 2 surgeries over the on average a year. Those tend to be mostly general surgeons, but we believe, and well, checking in the data, you see that they they have occasionally done these procedures, but their main activity is not this type of surgery. So they were just adding a bit of noise to our regression, so we have excluded them. And that leaves us with a sample of 1,466 consultants across all the hospitals in England, that are 198. Of course, we tested for differences in samples, and the only difference being the volumes. That is how we constrained the sample, but any other variable of interest was not statistically different between the 2 samples. So what would the outcome variable of interest in explaining is the diffusion or the adoption of this innovation. It's more the diffusion because we do it with shares. So we model it as the share of colorectal cancer surgeries performed laparoscopic. So it's the number of lap surgeries over total colorectal cancer surgeries. And then the variables of interest, that is our networks and peer variables, are based on a dynamic network that we built. And we assume that a physician is connected to another physician if they have worked at some stage in the same hospital. So we build this network for each physician from 1992 to 2014, and then use that network that is dynamic because there's movement of physicians across different hospitals. So it changes over time to build our variables of interest. That is the network size, so the number of connections, the degree of the network. The peer effect, the peer present and past behavior, as well as a variable that we call connection to a pioneer. And we defined being a pioneer, those that have adopted before the issuance of NICE guidance in 2006. Now, so this is just to tell you a bit how our networks look like. So if you think of these circles as hospitals and the dark dots as physicians, so there'll be here 3 hospitals, and in each of them there'll be 5 physicians. We see that, for example, for this person here, his or her network will be formed by these 4 other consultants, and the same for any other consultant here. So these peers, in the network of this doctor here. We are intra-hospital peers because they are the ones that are working with that physician at the same time T, in the same hospital. Now, because there is movement of physicians across different hospitals, the network is dynamic. So if we focus, for example, on
sorry,
this,
can I ask a question? Don't you have training on seminars or specifically about how to train for these techniques? Is something you only do when the technique arrives at your hospital?
So there is nothing formalized. There might be, we don't know. There was a training, an optional training program in 2009, LABCO, but that's the only known.
So this is really the way it works. You adopt the technology because somebody brings into your hospital, you talk to them, you're in the same surgery room, and then you move and you bring it with you. Okay,
yes,
thanks.
I mean, that's what we want to test. Actually, this LABCO training was one of the first of its kind because surgeons at this stage of their career, they don't have this type of formal training to adopt an innovation. So our hypothesis is that the mechanism by which they learn and then they adopt, it's through their networks, by observing, by talking to others. That's what we want to test.
Okay, so it just sounds so strange that such a revolution only happened from, you know, sharing a surgery room together someday.
Well, there might be other channels that we don't observe. So we just want to understand whether, you know, the networks and the peer effects are one of the possible channels. Institutionally, we don't, you know, there's no other formal mechanism by which senior or consultants, senior surgeons would learn about the procedure and be trained towards adopting it. You know, formally in the national healthcare system. But of course, there might be other channels. We have another paper where we look at guidelines issued by NICE, for example, and we show that, you know, well, we can't identify the causal impact, but we show that some consultants respond to guidance. So we are not trying here to characterize the full determinants of the decision making, but instead to identify the causal impact of these networks and the peer effects on the diffusion. But there might be others. But I think your question was more if formally in the NHS there are other mechanisms in place or training in place, and there is. And there, for this specific case, there was one launched in 2009 that was quite unique, precisely because the NHS doesn't have formal training for to introduce technologies and train doctors how to do it. Okay, so if you focus on this consultant here, then these consultants move in our network. So if this consultant moves from this hospital to that hospital, then you see that this consultant would have acquired 5 new connections. But, so this is again, what we call still the intra-hospital peers because they work in the same hospital, but would also have remained with the other peers that he had met in the previous hospital before the move, that we call the inter-hospital peers. So in T+1, this consultants network is going to be composed by the intra and the inter-hospital peers. So this is just to graphically illustrate how we measure the network and the dynamics of the network to some extent. Now, so we are interested in identifying the causal impacts of these. So our identification strategy follows 2 stages. So the first one is that we exploit these dynamics in the network that rises on patients moving across, doctors moving across the different hospitals to identify the degree and the pioneer proximity. Now, these, of course, this assumption, underlying assumption is that the network is exogenously formed. That is, consultants don't move across hospitals because of the take-up of lab. And that is quite plausible in this setting because all hospitals in our sample have, and in England, have the technology. So it's unlikely that doctors move because of the non-existence of technology in a hospital and existence on another. These consultants perform a range of other procedures, so they don't do only laps or open surgeries for colorectal cancer surgery. So it's again unlikely that they move just because of this procedure. Goldacker and colleagues have shown that actually most of the mobility of these surgeons between regions tends to be due to personal circumstances. So, for example, consultants wanted to go on leave closer to their families. But of course, we also test whether the network is exogenous, but looking at whether the mobility has anything to do with the take-up of lab, and we fail to reject exogenous mobility. So we can be quite confident that by exploiting, we can use these network dynamics to identify both the effect of the degree, so the number of connections, and the proximity to pioneer. Now, before moving to the second part of the identification strategy, to be important to show you how the adoption varies in the different parts of the network. So in order to do so, what we did was to do so descriptively, of course, to split the consultants and the hospitals into communities we used the community detection algorithm by Blondel. And what we find, it's here in these two pictures, here for consultants and here for hospitals, is that our consultants are mapped onto 5 communities. And these communities are mapped quite closely with the different geographical areas of England. So the Midlands, Southeast, Southwest, Northwest, and Northeast, and the same thing for hospitals. When we look at the frequency of the consultants' hospital year observations by community membership, what we see is that most of the mobility is intra-region. And then looking at the differences in the uptake of these different communities over time, we see that there is variation across the different communities, with the southern communities leading over the northern communities. Now, these variation or these differences in community uptake can be, of course, consistent with our hypothesis that peer effects will be one of the key factors. Because if positive, we would expect this to lead to different speeds of adoption. It's also consistent with differences in information transmission, with information transmission being different in different parts of the network. But of course, it can also be due to community composition through observable and observable heterogeneity at either the physician, the patient, the hospital, or the community level. So that takes us to the second part of the identification strategy. Now, we treat consultant and patient characteristics as exogenous. One could be potentially worried that more suitable patients, so there's patient sorting with more suitable patients sorting to high take-up consultants. Now, we claim that first, because we use consultant fixed effects, only sorting based on annual take-up would be problematic, therefore limiting its potential. But also because of this institutional feature that is there's a 2-week waiting time target. Patients can't choose, so this further limits the scope for sorting. We also test for that, and we failed to reject no patient sorting, and so we are quite confident that it's okay to consider the consultant and the patient characteristics as exogenous. We also condition on a broad range of things like hospital, community year fixed effects, on consultant observables, age and experience, and I'll explain in a second what is experience, how it's measured. Patient characteristics, so we build a suitability score, and then we aggregate it consultant level, but again, I will explain in a second how we do that. And also we condition on intra-hospital peers, characteristics to control, and the same like age, experience, and suitability score to control for hospital year level factors that might impact both the consultant and their peers' behaviors. Now, despite conditioning on all these sources of common heterogeneity, because of simultaneity consultant year level, we still need to be concerned about endogenous peers effect. And so we follow the instrumental variable approach to identify, to instrument the peer effects. That is, it's a quite common procedure in this literature, in that we use the literature on peer effects uses characteristics of peers or characteristics of peers of peers. So we follow the same procedure in which we instrument the peer effects using the characteristics of inter-hospital peers. And we focus on inter-hospital peers because it avoids weak identification that can arise when the network structure is close to one of intragroup interactions that it seems to be the case as per the graph slide that I showed you earlier. So this is our baseline specification. So again, this is the share of colorectal cancer surgeries performed laparoscopically, so our variable of interest. We are interested in this contemporaneous peer effect and another peer effect that is the cumulative peer effect. So it's the behavior of the peers up to t-1. We are also interested on the network size, so the degree variable, and to understand whether being connected to a pioneer or connected to someone that is connected to a pioneer has an impact on the diffusion of this innovation. We condition, as I said earlier, in a range of consultants' characteristics as well as patient suitability. And these characteristics are the patient suitability score, because we depart from patient level data. We run a logit in which outcome variable is whether the patient has received lab or not, or open, and we regress that on a broad range of characteristics that have been found to predict the utilization of lab, like patient socioeconomic characteristics, diagnosis, cancer severity and location, comorbidities, and near-DAMIs. We do that using the last 2 years of data, because we believe that is the time period where the procedure is more established. So it gives us, in a sense, the state of the art of the technology or the best practice. And then we predict a score, a patient suitability score for each patient, and we average that at consultant level. So that's one of the characteristics. The other is experience, and we measure experience in 2 ways. So we look at experience in laparoscopic surgeries in other conditions beyond colorectal cancer, as well as the experience in colorectal cancer surgery, so the volumes of each consultant. And this is measured as cumulative, both of them as cumulative volumes up to t-1. And then we also observe the age of the consultant. We also condition on the same 4 characteristics for the intra-hospital peers, so those that work in the same hospital, to control for for hospital level time varying factors that may impact both the adoption of the consultants as well as their peers. And then, as mentioned earlier, we use the same characteristics of the inter-hospital peers as instruments for our peer effects. So these instruments are age, both variables of experience, and the patient suitability score. So we have 7 exclusive instruments and 2 endogenous variables, meaning that we have our baseline specification is over-identified. We also, as I mentioned earlier, we also have a range of fixed effects. So we have consultant, hospital, and community ear fixed effects. Just to note that the consultant fixed effects control for time varying consultant factors, but in one of which that is important is the properties of their network pre-2000, and we estimate these as OLS as well as end-to-stage least squares. So before I move to the baseline results, I'd like to show you some descriptive statistics of our sample. What you have here are the different variables of interest in 2000, that is the beginning of the data, in 2014. And what you can see here is that there's been a diffusion of laparoscopic surgery, and these so the outcome varies between 2000 and 2014, and this is mostly driven by the diffusion of labs, as you can see here. Now, quite interestingly, the patient suitability score remains quite unchanged over time. So this diffusion, in principle, is not really explained fully by these, the patient suitability score, the patient characteristics. But you also see that the network evolves over time. So the degree, for example, changes substantially with a mean of 16 to 52 in 2014, as well as the proximity to pioneers. All these changes over time because the consultants move between hospitals. So this could be a good variation to explain the diffusion of this procedure. This is just the exogenous mobility regression. So just remind you, we assume that the network is exogenous, and we also test that empirically, in which we regress whether the consultant has moved in year T or not. Regress that on the take-up of the consultant in year T, its cumulative takeup upper to t-1, as well as the difference in takeup in year t and t-1 between the takeup of the origin and the destination hospital. And you can see that there's nothing going on here. So, we failed to reject exogenous mobility. So these are our baseline results. So here we have, we show standardized effects. These regressions, they all have the same level of fixed effects. They just differ in the instruments used. In each specification as a set of instruments. And our preferred specification is the fourth column, given the Klein-Barr PAP statistic and Hansen-J test. And what the results are pretty much very consistent across all the four two-stage least squares. So what we see is that there is evidence of contemporaneous peer effect, and this is and also while the being connected to a pioneer has a positive either first order or second order as a positive coefficient, suggesting that that would suggest that being connected to a pioneer would have an impact on the adoption. However, the coefficients are not statistically significant. Matteo, sorry, I have my 2-year-olds crying. But the network size of the connections, they are statistically and positive, significant and positive. Again, so suggesting that the number of connections, the size of one's network has an impact on the diffusion of innovation. Quite interestingly, you see that the patient scored as a positive effect, that as you would expect. So more suitable patients are more likely to get LAC. These, even though positive, the interesting thing is that when compared it with the peer effect size, the coefficient size, as well as the degree coefficient size, you see that this is less than half of the magnitude of the effects of both the peer effects and the degree. Okay, so we ran several robustness checks. I'm going to tell you about 3 of them, but there are many others that maybe you can leave to discussion if you have questions on those areas. So the first one is endogeneity of the patient suitability. So just to remind you, we have used the years 2012 to 14 to calculate the patient suitability score. And then in our baseline specification, we also include those years. Now, we fit the logic for the patient score on all consultants, so we are not really worried about endogeneity, but one could argue that there's some endogeneity concerns because each consultant behavior is used to determine those scores. So what you do as a robustness check is to remove those years, so 2012 to 14, from the main analysis and see what happens. We also use the last 2 years of the data to build this patient suitability score. And the reason we do so, it's because we believe that's where best practice is established. So it's towards the end of our data period. But one could argue that patient suitability is actually a concept that evolves over time. So as a robustness check, we use the years 2000. So we build the year-specific suitability score by using the years 2000 to 2014 to build the score rather than the last 2 years. And we do so by interacting the patient characteristics with the quadratic trend in the date of the surgery. And then the final robustness check I'm going to talk to you about is that in the baseline specification, we weigh equally the inter and intra-hospital peers, but one could argue that those that you have worked with in the past, you have worked them a long time ago, so they should weigh less in your decisions. And so we reweight the peer effects by the number of years since last working in the same hospital, with weights appreciating geometrically. So this basically just enables you to weigh less the people that you've worked with in the past in comparison to those that we work in now. So these are the results for these robustness checks. So here below you have the baseline results. Now, nothing really changes in terms of the main variables of interest, so the peer effects and the degree that I showed you earlier. When you look at the first robustness check, where you run the analysis just so you exclude from the analysis the last 2 years of data, we see that the key differences with the baseline results are the patient suitability score. And that now has a much smaller effect. And that is to some extent expected because we are removing from this baseline specification the last 2 years of data that is the period where you would expect the consultants to be more responsive to the patient characteristics. Analogous when we look at the other robustness check on patient suitability score. So when we build this time varying one, again, the results, the main findings for the key variables of interest remain the same. The key difference with the baseline is now the patient score coefficient, the magnitude of the effect is substantially higher than in baseline. And again, we think this is quite expected because basically this patient suitability score is to some extent capturing aspects of the patient behavior, because now we enable it to vary over time. And then finally, again, when we do the different weights for the different, based on the time since you've worked with that consultant, we see again that the main key effects are still there. The only difference being in this first two-stage square specification that the coefficient for the contemporaneous peer effect that was marginally significant and positive at 10%, it's now negative and not statistically significant. And we believe that's because the instruments are a bit weaker in the specification, with the Klein-Barr statistic falling to 0.4. Now, this was our baseline specification. Now, for the policymaker, okay, you find it's important to understand who, whether, so if we find evidence that there is a peer effect, then the question is, can we target these peers so that we stimulate the diffusion? So the first thing that we did towards informing a bit more policy was this key players analysis, in which we wanted to understand whether there are some peers that had a higher impact than others. So whether there's some sort of heterogeneity across the peer effects. And we wanted to identify those that would have the highest impact on the diffusion. So we defined the key players in the diffusion process as those consultants, the proximity to whom impact upon take up above and beyond the contribution to the peer network effects in our baseline model. So that basically means that we enlarge our baseline specification by including these terms here in red. Now, these terms are endogenous, again, like before. And so we follow the same strategy as before, that we use as instruments the patient suitability, the experience and the age of these peers. And now the issue is that by augmenting the specification to these, we end up with an additional 2,932 additional beta 3 and beta 4 parameters to estimate, and more than 10,000 additional instrumental variables. So we end up with a high dimensional instrumental variable model because the number of parameters and instruments is very large in comparison to our sample size. So the standard instrumental variables estimators are no longer appropriate. So what we do is that we reduce the dimensionality of this problem by assuming that these vectors beta 3 and beta 4 are sparse. All this means is that we assume that many of these are going to be equal to 0. So there are going to be very few key players with a positive coefficient. We don't determine what those are, but we assume that there are going to be few key players. And we employ the self-tuned instrumental variable approach developed by Eric. That is basically a reduction dimensionality estimator. Now, because this is a shrinkage-based estimator, then since it's biased towards 0, we also report a bias corrector estimator developed also by Eric. So these are the results of these key players. We run again the OLS and our baseline specification without key players, and then the final one is our specification with the key players. So we find that there are 35 key players, so 35 for which that beta 3 is different from 0. When you focus on those that have a statistically significant coefficient of 5%, there are 13, and their mean effect is 0.26. This is a large one, but if you compare that with the contemporaneous effect, it's smaller in magnitude of the effect. When we look at proximity to the key players, again, we find 10, and the coefficients, the order of effect, the magnitude of the effect, it's commensurate with the pioneer, the proximity to pioneer effect. So the proximity to the pioneers that we had found before. Then we were interested to understand, okay, who are these key players? So there are some of them, 35 of them. Who are these key players? What are their characteristics? So when we compare the characteristics of these key players with the rest of the consultants, we found descriptively that they have earlier and faster take-up than others. They are more likely to be pioneers. They're also younger, and they tend to be located in specific hospitals and regions, in particular teaching hospitals, specialistic hospitals, as well as smaller communities with lower average take-up. We are then thinking, okay, so we find that there's these peer effects, that networks make a difference, and there are some peers that have a stronger impact than others. So can a policymaker use these to spread the diffusion of innovation? So we simulate these insights to design policy to spread the diffusion of innovation. So what we do is that we simulate the effect of two policies. One that we call the early take-up policy. And this policy would consist of selecting one consultant in England, in the entire England, just one, with a policy, the effect of, in 2001, the effect of which would increase the take-up by 0.05 in the years 2001-2014. So we do that, and this could be, for example, achieved with an individual training program. So you select the consultant and you train that person so that the take-up increases by that amount. So we do that by increasing the steep error by 0.05. So what we do is that we pick up every single consultant that we observe in 2001, and we implement this policy. So we end up with a range of counterfactuals, so one counterfactual for each consultant that is targeted. So we do these data set counterfactuals, and each data is going to be different, because if you target one consultant increasing its uptake, then that's going to propagate in all the other consultants through their peer effects and their connections. And then we select the counterfactual, so the consultant to target based on getting a mean take-up in 2000, and the highest mean take-up in 2014. So what we find is, so here in black, so here you have the take-up over time, the diffusion of the technology. In black is what we observe in the data. If we implement this early take-up policy, you find the effect would be the one associated with this solid red line here. So you would see that the take-up would increase over time and will be above what we observe in the data. Now the question is, who should be targeted? Okay, so we just picked up a counterfactual, but the question, we don't know whether, so the policymaker would need to understand what are the characteristics of that person to be able to develop a policy and select actually the consultant that would lead to the maximum early take-up policy. So what we do is that we regress that mean take-up in 14 for each of the counterfactuals on the consultant observable. So the characteristics of the consultants are observable to the policymaker in the year 2000, and we denote this as the feasible policy, and it's feasible because it determines the characteristics observable to the policymaker that couldn't be leveraged to select that consultant and target that consultant. So in this table, you have actually the first specification is all characteristics, but you have characteristics such as key players and pioneers and proximity to pioneers that are things that wouldn't be observed for a policymaker in the beginning the diffusion in 2000, so in the beginning of when the technology was implemented. But then you have a range of other things that, so you have its own take-up, you have the volumes of that consultant and the age and so on and so forth that are observable to a consultant, to a policymaker. So the results from the second specification suggest that this policy would need to target a young consultant. Well, will be more successful if it would target a young consultant with relatively high take-up and a high number of surgeons, so volumes performed, and the one that is reasonably connected, so a high number of so a large network to some extent. And if the intervention, if such an intervention policy would be implemented, then the policymaker would achieve an increased average take-up of 17 percentage points relative to no intervention. So this is quite significant impact if you think this is just about targeting one consultant. Then, this is just to show you that. So the solid red line was the early take-up policy, assuming that any consultant can be targeted. And the dashed red line is the effect of this one, that is the feasible one, because it is the one that the policymaker can, in which the policymaker can use the observable characteristics of those consultants in 2000 to select the one that is most appropriate. So the effect is smaller than the other one, as you would expect, but it's still higher than, it still leads to this 70% increase in the diffusion of this technology. Then we wanted to simulate the effect of another policy. So this is a bit more complex policy, so likely to be a bit more expensive and harder to implement. It's a networking policy in which we connect the low to the high take-up consultants in 2000. And this could be achieved, for example, with a rotation program. So the low take-up consultants are those, we define those that had 0 laps in the beginning of our data. And they were poorly connected, so they had at most 10 connections. So they are in total 153. And then we identify the high take-up ones, that are those that in 2000 at the highest take-up. And there are 10 of them. So if we would implement a networking rotation program by which we connect these people, we would end up with 147 additional connections. That is a 1.1% increase. By connecting for each low take-up consultant, if one did not already exist, we would add a link to the nearest member of the high take-up group, okay, in the 2001 network. So this leads to this amount of extra connections, and these counterfactuals, when we compare the uptake, the average take-up in 2014 of these counterfactual with what happened, you see that will lead to a 23 percentage point increase in the diffusion of the innovation. And this is represented here in this dashed blue line. So this, you see that this is a bit more effective as a policy. However, it's likely to be harder to implement. They're also more costly to implement the targeting one consultant like in the early take-up. Okay, this is what I had to tell you. So we leverage this quite unique data set to study the causal impact of peer effects and network effects on the diffusion of laparoscopic surgery for colorectal cancer. This is a very good data set because it enables us to construct dynamically these networks for the physicians for an extended period of time, even before the adoption of the innovation. And we find that there's evidence for peer effects as well as network effects on the diffusion of this innovation. We don't really assess formally the mechanisms for these effects, but our results are indicative that these effects are through peer learning or imitation, as well as information transmission that is caused by the mobility of the consultants across the different hospitals. And then we also simulate a couple of policies by which we see, well, if these things make a difference, then policy makers can design policies to based on networks to increase the diffusion of the technology. So we show you the 17% increase in the diffusion with a policy that it's very likely to be very cheap to implement, because you just need to target one clinician with an intervention that increases its take-up by 5%. And then we show you a bit more ambitious policy to implement that connects low take-up and poorly connected clinicians to high take-up clinicians. And this, even though a bit more tricky to implement, will lead though to a higher diffusion of the innovation. And that's all I had to tell you. So thank you.
Thank you very much.
Thank you.
That's very interesting. So I'm not sure that we have physicians with us. So I will play this role unless Anya or Hilde, do you see any question from the medical side? Otherwise, I will play this role to start with. And I'm sure that I see many economist colleagues which will then continue the discussion. But from a medical surgical perspective, perhaps one or two questions. Actually, laparoscopic surgery was a clear improvement. I think that there is not much debate on this. Now, after laparoscopy, there is another technology, which is robotic surgery, which appeared. And I think that there it's less obvious that robotic surgery is adding something to laparoscopic surgery. And I'm just would be curious actually to know what's the situation with robotic surgery, and indeed which are the factors which might drive surgeons to adopt robotic instead of laparoscopic.
So that's a very good question. Actually, when we started this project, we wanted to look at robotic surgery, but then it was very hard to identify it in the data. And also there are very few, it was not really widespread in the data. So I think diffusion was a bit slower than this. And also there's a rather, all range of factors that will trouble our identification to some extent, because it's a very, expensive piece of kit to have in a hospital. So there's management issues and hospital level factors that will play a role. But actually quite interesting. So we never really assessed the robotic surgery. And in all honesty, I'm not entirely sure this can be the results, the findings we have here can be generalizable to robotic surgery. But I presented this seminar in Bocconi last week, actually, and some colleagues there have found, albeit with different methodologies, so their study is a bit more qualitative and triangulates that qualitative data with archival data. But they looked at the diffusion of robotic surgery in Italy, and they found very similar impacts. Their methods enable them to characterize it, because it's a bit more qualitative, characterize a bit better the factors that influence the diffusion in the different stages of the diffusion process. But largely they found the peer effects and connections do matter also for robotic surgery. I need to read a bit better their paper to be able to give you a bit more the magnitude of the effects, but basically that's what comes out. I think it's a paper in the Academy of Management. It's not published in the Academy of Management journal.
No, that would be interesting. It could be an interesting follow-up, because I think that the factors driving adoption might be quite different indeed. So, any questions from my economist colleagues? Mickey?
Okay, Matthias, you want to start?
Okay, well, thank you, Marisa, it's quite interesting. I had a question on, intuitively here, I guess the assumption is that faster adoption is better. But at some level, they can also be something like excessively fast. innovation, and possibly even that maybe in some cases innovation adoption is not a good idea. So now listening to Michelle, it looks like this implicit assumption is a good one, but I don't know whether you thought about that and you have comments on this question.
Yeah, I mean, that's a very, very important point. I mean, the paper, the part that I'm more excited about this paper, it's the counterfactual simulation of policies. But of course, in 2000 and 2001, there was so much uncertainty still about the effectiveness of this technology that it wouldn't potentially be desirable. Well, it could be, depends really on how much risk averse or what is the value of information for the policymaker. But one could argue that it was not yet established whether it was safe enough or effective enough or even cost effective at the time to let to pump the diffusion of this innovation a bit quicker. Maybe it's better that it's as slow as it was, so that you would see, there'll always be the pioneers and those that lead the innovation adoption, and see what happens with their experiences and then reflect, and so I don't have a clear answer to you, just that it's true that these policy recommendations, especially before 2006, when there was still a bit of uncertainty about the real value of this innovation for the NHS, not only in economic terms, but also in terms of effectiveness and safety of performing these procedures in the English context. One could also argue that these policies are good, but at the time, it's even if they could be implemented and they could have led to that amount of increased diffusion, maybe it was not desirable from a policy perspective because there were such high levels of uncertainty. So maybe this is better to wait and see how people experience, to see their outcomes, and then take the decision a bit later with a bit more information. Yes, so there's no way we can assess that. Well, actually, there's a way we can assess that, and that's we had intended to do it as part of this research program, but then it just took so long, every single analysis, that we paused that for a while. That is to look at the outcomes, right? So the impact on outcomes, on patient outcomes over the diffusion process, and also simulate those in our policies to see whether they would have been meaningful, better or not, or actually even worse if you would have a quicker speed up diffusion process.
Thank you.
Yeah, actually, if you engage in such studies, it might be necessary to make a distinction between the different types of cancer. Because my understanding is that rectal cancer is much more, create much more problems when it comes to laparoscopy than the other forms of colon cancer. But that's another question. Any other question or remark?
Well, I had a question quite related to Matthias's. Here, what the exercise is, I take a technology that with hindsight is a technology that had such drive that despite the lack of organization, etc., took off, okay? And so exposed, we can reinvent the past and say, okay, what if, okay? And that's, I think, what Matthias was pointing at. So in terms of policy, how would you recommend? So we know all the industrial disasters when government said, okay, that's a champion, let's push it. So here you must have in mind a number of technologies, some that proved exposed amazing and exposed very bad. How would you design this recommendation from an ex ante perspective? So when would you make which kind of interventions? Would you try small networks to evaluate, or what would be the different phases for that when you're looking ex ante and you don't know yet?
I mean, again, this is something that we haven't explored, but my gut feeling is that, and this is something I really wanted to do in this project, but it was not feasible, first is to measure outcomes. So what happened to the patients under this, so to try to learn a bit exposed so that we can then examine these policies. There's a lot of heterogeneity across the different consultants on how they perceive, even how they read evidence. The same evidence is interpreted in different ways by the different consultants. So one of the pieces that I wanted to do, this could inform that discussion, is to try to understand those, if you want, more micro behavioral factors of the decision making, see how those correlate with outcomes and performance of each different consultant, and then that could be something that could be potentially leveraged to ex ante design that type of policy. You don't really want, I mean, and this is one aspect, so that they kept on citing to us. I mean, we spoke about the same evidence with all the consultants we interviewed, and some said yes, but that evidence would say X, the other side it said totally different. So their interpretation of the evidence and whether they think it's robust evidence or not, I think is clearly a factor that not only determines, well, that will to some extent determine how confident or to some extent overconfident they might be when something, an innovation pops up. And that can certainly explain, at least that's my hypothesis, because it hasn't been touched, some heterogeneity in performance or in outcomes across the different doctors. Another thing that, but this again is very specific to surgery, is that a lot of these things will require some, this is something that again they kept on referring to us, some handability, right? And you need to be very precise with laparoscopy. You need to have very still hands and have certain handability to do laparoscopic surgery. While when you do open, you cut fully your patient, and so it's much easier physically for a consultant, because just cut everything open. You need to be you need to cut in the right places and then move in the body with a tiny camera and a tiny instrument, laparoscopic surgery, meaning that if you're not very agile, then you might actually even harm the patient and cause major bleeding internally. So many of them said, I'm an old dinosaur, and all my life I've been trained physically for my hands to operate in a certain way. So it would be very hard for me now to relearn everything. And they really emphasize that this mechanical aspect, this physical aspect, was extremely important in surgery. So again, this is something that from a patient safety perspective, and again, whether this is desirable that it spreads as quick as possible across all different consultants. This is something that could be, so your years of experience in an alternative procedure, for example, and how so that the impact of this handability to some extent in performing the surgery, whether that requires further training or not, and that certainly plays a role, and that's something that again could be measured with some proxies from a policy perspective ex ante to inform that. There were some consultants, this is the elderly ones, that this is like a joystick, right? This new, so it's like and we don't know. So the young ones know, because they've played video games with joysticks all their lives, and this is very similar to that type of technology that requires a bit more physical ability that I don't have. And again, this is another, again, this will need to be tested, right? And this will vary between the different procedures, but that ability is something that and the heterogeneity in that ability, more importantly, is something that would impact how quickly these should diffuse, but also who should be the ones among which should diffuse from a public health perspective and from a policy-making perspective.
So we have now a question by Antonio Estache. So I don't know if you know Antonio, Marisa, but he's a well-known economist, and since a few months from now, he is working closely with Vincent Donquier, the head of surgery at Bordet Institute. So he's the one who sent me during the weekend these two papers.
Lancet.
So Antonio, the floor is yours.
Thanks a lot. Thanks a lot for the presentation also. I don't know if you hear me.
Yes.
Okay. I have a suggestion actually for a Brexit version of the paper.
Brexit version, yeah.
Yeah. Can you control for external networks? I mean, all of your networks are domestics.
No, unfortunately, no. We know. Okay, so unfortunately, we can't. And this came as important in our qualitative research because some of them said they would go and train abroad. But we can't observe that. I mean,
You know where they studied?
That we know whether they studied internationally. That we know.
That would be my proxy.
Yeah. Okay.
It's just, I mean, this is the right time to talk about the consequences of Brexit on innovation. That's one way of contributing to the debate.
Yeah, and thank you for helping us fighting Brexit. Yes. Yes, I can't recall. I think we did look. So we start looking into that because we had observed these consultants that were there and then they disappeared from the map and then they came back again. And they were not only not doing correlative cancer surgery, but actually they disappeared from the entire system, right? They were not doing, for example, other type of surgeries. And then we start investigating some, and I think, we can look at their training, their formal training, but there's a lot of gaps and consultants that, speaking to them, they tell us we go abroad for periods, especially, before we become senior consultants, or if something like this comes up, we go and train with the best. A lot of them mention the US for this specific procedure. So, but it's an empirical question. So thank you. Yes.
But I really like the idea that you went into lots of details on the demographics. But I don't know whether the paper actually gives us more details. I mean, I'm just thinking about, you just mentioned earlier when you were answering a question from Michael about age as a relevant variable. Gender may be a relevant variable.
So gender was something that we really wanted to look at, but there were, I can't recall the number, but maybe 10 female surgeons in this area. So that was quite appalling. So
that's in itself information.
No, that's an interesting thing. So, but we couldn't see. I mean, qualitatively, even quantitatively, you see that they adopt earlier than, but again, they're 10 in comparison, or maybe they are, 20 in comparison to 1,000 something. So there's nothing we can say much there. We looked at where they trained, and in particular, whether there was an effect that I didn't show here, but, we explored a lot, if they trained at university hospital, a place that does research and develops innovation, whether there was not much there, except from the things that I told you about the key players. So people that train in those places, they tend to be, for example, key players or pioneers, but we didn't see any heterogeneity in the diffusion, in these impacts that we are showing. So
I think these non-results are quite interesting.
Sorry?
These non-results are quite interesting.
Yeah.
Thank you very much again.
Thank you.
Thank you, Antonio. I think that there is another question by Matthias.
Yes, thank you. Coming back a bit to what Michael was saying about, indeed, again, about speed and the like. One, and maybe I missed it in your presentation, but are these people who make recommendation without conflicts of interest? It can also be just being over convinced. It works for me, so it must work for everybody. And then there is the darker side. I recommend it because there is something in me for that. Well, Sophia did work on, adoption of medical devices and the link with the kind of lobbying a bit by companies. In the end, it wasn't a problem, but is this something that could be a concern or not?
Yeah, I think it can, and that's actually where we wanted to start. We wanted to look at these, characterize a bit better the behaviors, but also the attitudes towards innovation. That it's something that you never, at least at hospital level, even primary care level, you never really observe anything about these doctors. So our goal when we started the research program was actually to do that, to not knowing just their age, where they trained, because that more or less you can get from any data, but trying to look at more other factors that we know that will have an impact. So we're interested in risk and time preferences, because they will play a role here in the behavior. Any conflicts of interest was not something that we were interested in the beginning, but we learned from the surgeons that most of the technology is actually sponsored by industry. Actually, almost all of the technology in a hospital settings is sponsored by industry. So they will give it for free, bits of kits, so that the surgeons would do. Now, the extent to which each consultant has a conflict of interest in those regards, again, can play a role. It was not something that a priori we had planned to look at. We are also interested, especially on how they interpret this innovation. So, what I was telling to Mikael before, that the innovation is not black and white, right? So your interpretations and on which side, how positive you are about each piece of evidence that comes across, whether you think it applies to your patients or not, and also how much of a fan you are of this technology. We spoke with the leaders in the diffusion of this process, and you could see from their voices, they wanted everybody to, they said this is and they were actually quite old surgeons, more very senior surgeons. So they really wanted this to spread among everybody, and they thought that everybody should be using these. And then you would speak to other people that even among the doctors, that they thought that was not the case. So I think these behavioral differences and their determinants, would explain a lot of these differences in behavior. Unfortunately, that required us to get to learn, because our plan was to learn about these attitudes, these economic preferences, these attitudes towards innovation, and build these indicators at consultant level, and then go back and link these to each of our consultants on our data. But the data provider thought that was too much information for us to know, because we, in a population that has such few consultants, we would easily be able to identify each. I still don't understand how, because, things like attitudes towards innovation, overconfidence, risk preferences, time preferences, there's no way you can figure out who is who, but it was perceived as such. So we were blocked from running any questionnaire with these consultants. We just had to rely on the data that we had. But certainly these things can have an impact. And many of them did mention that a lot of the innovation that industry is a key player in fostering the adoption of these technologies in hospital settings, and they give things for free. They give training for free, they give piece of kit. So not only they will have an impact on the diffusion, but I think more importantly, if there's conflict of interest, you might have these very strong advocates that might, again, this is an empirical, it needs to be empirical tested, but you might have those that are overconfident just because, they've been exposed to that type of incentives by the industry. But again, that's not something we can test, unfortunately, with our data. If you have some nice data sets, maybe we can do it.
No, I think, if I may, it's a very interesting and important discussion. And the point I would like to make is that in that sense, surgery is very different from the other, I would say, therapies or therapeutic technologies. And the problem is that in surgery, there are few well-performed randomized clinical trials. And I think that this might be a source of reflection. I know that, RCTs, I learned this through Matthias, is also a hot topic in economy and in economics. And obviously in medicine, it's a cornerstone of the so-called evidence-based medicine. And, there is not real evidence-based surgery, because you are so much dependent on, the personal skills of the surgeons. And I think that, I don't know, but this could be an interesting topic to investigate, the difference in, pharmaceutical therapy versus surgical therapy in terms of the parameters which will lead to adoption of an innovative therapy. I see that Sophia is with us. So perhaps, Sophia, you can also make a comment on this after Marisa and answer to our question about how is your baby?
That's the important thing.
Oh. Hello, everyone.
Actually, how is Mama? Because everybody asks about the baby, but it's Mama that needs to be cared for.
Getting better. Thanks. No, I'm sorry that I was actually a bit late, precisely because of the baby. But I was actually wondering. So in your data, it's impossible to have the physician identifier, right? You don't know.
No, we do. No, we know we have an anonymized identifier, so we can follow this person over time, and we know
not the name.
No, not the name. We tried. We're a bit naughty. We tried based on our qualitative interviews. I think we can identify like 4 or 5 because we know where they've trained. We know them. I mean, they are our colleagues at university, right? So we know exactly their backgrounds, and looking at their CVs, we can see them in data, but we can't do that systematically for all of them.
No, it just came to my mind because you're asking also about data sets. So before when I ended up doing this project that Matthias just mentioned using US data, but I was actually trying to look in European countries, those who would have available a kind of a list of interactions between physicians and the pharmaceutical or medical device industry. And there was actually some information available for UK. To be honest, I checked this a while ago. I can actually check if I still have those files. And it was quite transparent. To be honest, I don't remember if it was also medical devices or only pharmaceutical, but they had the name of the physician that was getting some kind of interaction with the industry. So I can also have a look at, you know, if I still have those kind of files and whether you could do something with that.
Yeah, I mean, our goal was to, you know, get us, I mean, not that we are not thinking that was not one of the things we were looking at, but this actually came out as very important, as you highlight, even from the interviews you made with them. Maybe it's less important in the context of lab surgery because there's not many strong incentives that you need there. But if you think about robotic surgery, for example, there's lots of, you know, large amounts of capital that are being, you know, given and injected in hospitals that get this kit for free. But I mean, our problem is really how we can then identify the consultants in the data. I mean, we had proposed our data provider that we will run these questionnaires and get this information and they would link it. They requested that we would have an intermediate. We contracted Ipsos Mori, but they found it such a challenging project because of the target population, because these are senior surgeons in cancer, as one of them says, the most arrogant medical type that one can encounter. This is these words, not my words. So Ipsos quit. We offered them a huge amount of resources and they quit 4 months into the project. So we couldn't, and so they didn't allow us to do that. So we ended up doing something a bit different. But yeah, I mean, if you have the data, I mean, some things, I mean, we can at least characterize them by hospitals, right? So that would be interesting to know. So we could look, even if we can't identify each of them individually, there are 5 or 6 per hospital at each point in time of these consultants. So we could characterize the sponsorship, industry sponsorship and conflict of interest by hospital. So yes, that would be very helpful.
I'll have a look.
Thank you.
Thanks. Thank you. Very interesting.
Any, Matthias, your hand is
permanently on.
Sorry, I forgot to.
okay. So any further question or comments? So if not, Marisa, I would like to thank you so much. I think that we learned a lot, and for me it was really a perfect example of what we are trying to develop at I3h, you know, these interface and to investigate these interconnections between medicine, health, and economics. And yeah, I think that Sophia was very much engaged in this direction, and we hope that perhaps through her we will be able to keep some interactions in the future.
Yes, we should do some collaborative research.
Sounds good.
So thank you so much, and enjoy your afternoon.
Thank you. Thanks so much for the invitation and the wonderful comments.
Thank you.
And keep safe. Take care.
Bye-bye.